recording? If you are, just pick someone else. Is that right? Or you just leave it? Okay, that's not mine. Okay, then get your ass over. That's gonna be on. Can you edit that out? Yeah. For a price. What, an A? Is that what it takes? I'll send it to you.
Did you go over supine rib?
Sorry?
Did you go over supine?
That's what we do now. Yeah. And so for the supine rib, that's good. Now, you notice how he slid down a little bit? That's perfect. Because in some of the tables, you got to make sure that you have, the table in the location where you're working. And so you just have to move them around properly for being able to do that. So for the supine rib, what I'm going to do, and again, this is a very important movement right here, this movement in my hand. When I do this, and here's the table, that elevates my thenar eminence, and that's going to be the contact for the rib. It's going to be the same location, so it's going to be medial to the scapula, but lateral to the transverse process. So you're going to feel underneath there. And again, if it's a superior rib, I take an S to I tissue pull. If it's an inferior rib, I take an I to S tissue pull in that kind of process. Then I'm going to stress and thrust from anterior to posterior. I'm going to be taking the entire shoulder girdle and bringing it posterior, but I'm also going to be right on the rib itself. If it's a woman, she's going to cover the breast and hold it out of the way, and that way you can get to most areas pretty well. So again, hand behind your neck. This position, if you're comfortable, is that comfortable? That's a little tight for you, isn't it? Yeah, a little bit. Okay, so we'll do the other one, so just show them this. Because you don't want to become uncomfortable, because you can cause problems in this process. Let's take an example. If someone had impingement syndrome here with a biceps tendinopathy, you're putting them in the position where you're pushing the coracoid process right into the tendon. If they're not comfortable, they're not going to relax. If they can't relax, it's not going to be effective. So an option would be to put the hand right here. And so I find that if they're comfortable to have the hand behind the neck, that seems to work better, but you got to do what you got to do. Here's another one. Most important body when you're working on a patient is your body, right? So double drowning, we avoid double drownings. And so to help me, ergonomically to help me, I'm going to have you scoot toward me a little bit. So move toward me a little bit, that's perfect. And so that way I don't have to lean over him. And it helps to protect. And again, if you're a woman, let's pretend you're a woman, you cover the breast. Excellent. So now I got to make my contact, get my contact medial to the scapula. So what I'm doing is I'm stretching them this way. I'm feeling the medial board of the scapula. I find the rib I want to contact. I place my thenar eminence right in the location. And now if you look at his body, I'm doing this. What I'm doing here is this motion right here, which simply lifts my thenar eminence against his rib. Now my pisiform comes on the exact rib that I want to adjust. And notice what's happening here. My shoulder is pushing and retracting his scapula at the same time that I'm going to thrust right on the rib that I want to adjust. And typically you take a breath in, and as he lets it out, I just drop on both pieces at the same time, and that's the thrust. Got it? Thank you. Steve, come on, sit up. Let's see what we do next. So wait, you're not done. On your back now. So now we have the dislocations, and you should know the whole process with dislocations, be able to do that rapidly and smoothly in the process. How do I know that they have a dislocation? I see a flat deltoid. I palpate a flat deltoid. Before I go through the process of reduction, I need to make sure that they have a good, strong pulse, and they don't have a pulsatile mass high in the axilla. I'm also going to test for sensation on the lateral deltoid to check the axillary nerve. You should know axillary artery injury, which is quite rare, 1 or 2 out of 1,000 cases. That contraindicates reducing a dislocation. We put direct pressure high into the axilla, and we call 911. Pray if you're into that. If they have nerve loss, that doesn't prevent us from reducing the dislocation. You should notice the difference. So we determined they don't have it. We've ruled out axillary artery injury. We've diagnosed the dislocation. So now we can reduce it. So we ask for consent. Would you like me to try to help you reduce it? And he says, yes, that's good. You got consent. And now you go through the process. And so the first one is the Coker maneuver. Is that the first one listed there? Yeah, Coker maneuver. So we have several maneuvers for this process. Remember, by the way, with every one of these, you can have an assistant or someone you just find in the area push the inferior angle of the scapula medially, so they're adducting the scapula, and that's called scapular manipulation, and that can assist the process. And sometimes I've had cases where that was necessary. Okay, so now first with the Coker method, we're going to distract and externally rotate, so you just relax. I want a broad contact on the forearm, and notice the position of my elbow here. And I'm going to push the humerus inferiorly and then externally rotate. By the way, during this whole thing, you're going to tell him to relax as much as he can. That's the most important thing, is to calm him down. I want you to take slow, deep breaths. I want you to look into my eyes. I'm not going to do anything you don't want me to do. You know, and so he knows all that kind of stuff. And you should say that to your partner. Okay, now I'm going to distract and externally rotate. Very often, this is where it reduces. But if it doesn't, I maintain distraction and external rotation as I flex and adduct. And oftentimes, this is where reduction occurs. So in this position right here, I'm actually pushing against the rib cage, which levers the medial part of the humerus away from the glenoid and up over the lip into the glenoid itself, glenoid fossa, and then we internally rotate. If we can get him in this position, that means we're effective. You know, we maintain this position and have him return. So that's the Coker method. Any questions? We have the Milch method. Starting again, the same procedure. Take deep breaths, look into my eyes, won't do anything you don't want me to do. Check the artery, check the artery, check the nerve. Now, I'm going to hold the forearm as I'm maneuvering him. I'm going to stabilize the humeral head. So, you know, his humeral head, which is here right now, could be anywhere around here. So you're going to palpate for it. And I place my thumb horizontally, not the tip of the thumb, but the broad contact of the thumb, just inferior to the humeral head, to prevent it from sliding inferiorly as I slowly and gradually move him through the range of abduction and external rotation. And we go all the way up. And he's taking deep breaths, and he's looking in my eyes, and we're talking about, you know, games or whatever, politics, whatever keeps him calm, probably not politics. If you can't go through this range, you can go through this range. Again, passive movement as far as it takes. What happens is we just have to get here.